I thought of doing this bladder and bowel dysfunction in children. It is one of very important and upcoming topic in pediatrics. And to start with, look at within next half an hour or 40 minutes or so, what are the things that we are going to discuss. And we look at what this bladder and bowel dysfunction is, why it's important, what is the underlying pathology, and how to evaluate and how they, especially how they present clinically, and the evaluation and the treatment in briefly. And what is bladder bowel dysfunction? If you look at the literature, there are a lot of definitions, but I have taken one of the definition from one of the position papers. It means that is defined as a condition of combined bladder and bowel disturbance that does not explain pathogenesis. There's another important part to this definition is that you can't identifiable or there is no any recognizable underlying neurological abnormality. Therefore, there should not be any neurological abnormalities. There should be a combined bladder and bowel disturbance, and usually there is no explainable underlying pathology. Why is it important? To highlight this importance, I would like to share a few studies which has been done on this. And this is the position statement from the International Children's Continence Society and about diagnosis and management of bladder bowel dysfunction. If you look at this position paper, they have reviewed about 216 publications. One of the most important, the key message is that if you fail to recognize the BBD, you may not be able to predict the spontaneous resolution of the VUR, or even after when we are anticipating the surgery and when we are considering the surgery, it's very important to look at whether the child is having underlying bladder and bowel dysfunction. And why this is important? Why this is important is that now we all know if you take a primary vesicular reflux, we know there are mild degree reflux and the higher degree reflux. And when there is a higher degree reflux, the resolution will not be as usual. But if it's a mild degree reflux, vesicular reflux is grade 1, 2, and 3, we know more than 50% or up to 80% will resolve when the child reaches about 5 to 6 years of age, right? But here, now, if the child is having underlying bladder bowel dysfunction, you can't predict your spontaneous resolution of primary vesicular reflux. That's another important thing that we need to keep in our mind. And if you look at the children with vesicular reflux and recurrent UTI, there are about half of them are having underlying bladder bowel dysfunction. Another important thing that we need to recognize. When child present with the recurrent UTI, if we diagnose vesicular reflux, half of them are having underlying bladder bowel dysfunction, which need to be evaluated or looked for. Otherwise, we may easily miss that condition. If you further look at done in India with Aravind Bayan's team, and again, this is a prevalence of bladder and bowel dysfunction in toilet-trained children presenting with recurrent UTI. There are another important few points that we can appreciate from this study, and it shows that BBD is common in toilet-trained children presenting with UTI with or without primary VUR. Again, another important point is that if you look at the primary VUR or primary vesicular ureteric reflux, they present early in the life with UTIs within the first 2 to 3 years. But if you look at the bladder bowel dysfunction alone, they present a little bit late. They present a little bit late, especially the preschool age, or after that, they can present with recurrent UTI without history of UTIs during the early childhood. Therefore, this will tell you when it comes to the clinical presentation, those clues will tell you or lead you to diagnose this important condition. And the associated functional constipation is very common in these children. And if you look at the data, almost every third child with bladder bowel dysfunction or coming with the recurrent UTI with variable bladder dysfunction having associated constipation. And finally, we can conclude that both BBD and VUR double the risk of recurrent UTI. And how does it happen? Now, if you look at genitourinary tract and gastrointestinal tract, they share the same embryological origin. They are in the same location in the pelvis, and there is the same innervation and same route to the levator ani. Therefore, this close proximity of the bladder and the urethra to the rectum make it very likely that abnormalities within one system will affect the other. And further, if you look at this diagram, you can appreciate that how the loaded rectum can pressurize the bladder neck and the bladder, where you can end up with having irritable bladder symptoms and also the incomplete bladder emptying. Therefore, this close anatomical proximity is one of the main aspects when it comes to this condition, where the bowel and the bladder both get involved. Now I am coming to the most important part of the clinical presentation. This is a part that very important to us, and they present with different clinical scenarios. To start with, we look at the clinical presentation. The overactive bladder, they can present with overactive bladder, dysfunctional voiding postponement, extraordinary daytime urinary frequency, underactive bladder, recurrent urinary tract infections, and the constipation. The last two, the recurrent urinary tract infection and the constipation, is a separate, wide topics. Therefore, I'm going to the first five, the urological presentations mainly. The overactive bladder, dysfunctional voiding postponement, extraordinary daytime urinary frequency, and the underactive bladder. Those are the common presentation when it comes to the bladder bowel dysfunction, mainly the bladder symptoms. To increase your enthusiasm, I would like to go for a small case history to start with. And you can see this is a 6-year-old boy presented with febrile UTI, several episodes in the past, and he has been tried on prophylaxis. And bladder and bowel diarrhea revealed only 2 to 3 voids per day, take longer time to empty the bladder when we inquire from the parents, and there is associated constipation. If you look at the ultrasound scan, one of the basic investigations we do, the child is saying post-void residual volume of 20%. Then he has been referred for the uroflowmetry. We will discuss at the end of the presentation. Now, before we discuss these urological presentations in bladder bowel dysfunction, it's very important for us to know at least few definitions or few terms. If you like, decreased daytime voiding frequency is referred to as 3 or less voidings per day. Increased daytime voiding frequency referred to as 8 or more voidings per day. Polyuria, we all know, is more than 2 liters per square meter body surface area for 24 hours, or if you calculate hourly, it's more than 5 ml per kilogram per hour. And for the urological, for the further bladder assessment, we should have some idea about the expected bladder capacity. It's dependent on your age. There are some formulas to calculate that. Now, if you look at the overactive bladder, this is the first condition I am going to discuss. And this is the most common urological presentation of bladder bowel dysfunction. The hallmark of overactive bladder is urgency. And 60% of children presenting as incontinence. Therefore, this is a very important clinical presentation, urgency and incontinence. And then, if you evaluate the history in details, you can appreciate that there are associated holding maneuvers in the or sometimes they stand in tiptoes to make sure to keep the continence, Or there is another important sign called Winsett-Curry sign, where they crossing the leg and try to keep the continence without passing urine. Therefore, urgency is a mark of collective bladder, and it is the commonest presentation when it comes to these urological presentations. Dysfunctional voiding is more serious condition where we know there are two sphincters, internal and external sphincters. When the child is contracting the bladder, these sphincters has to coordinate and relax for child to pass the urine. And here, the children contracts uterus sphincter during voiding. Therefore, there is increased bladder pressure developing in these children. There is associated constipation. And if we look at the uroflowmetry, there is a typical pattern you see, staccato pattern you see in the uroflowmetry. In most extreme situation, sometimes these contracted sphincter behave as a physiological obstruction. And there is a potential for significant morbidity at the bladder and the kidney level. As I mentioned, the bladder pressures can go up and it can affect the upper flanks. And this syndrome and its extremity was labeled early as Hinman-Allen syndrome. Now we rarely use this term, but earlier the extreme stage or extremity of this dysfunctional voiding was called as Hinman-Allen syndrome. This is a more serious condition because it can affect the upper easily. Then there is a voiding postponement, especially you see in small children. They tend to delay urination while distracted playing, and it results and it's initiated on holding maneuvers, and it ends up with the low voiding frequency, urgency, and sometimes daytime incontinence, and due to the full bladder. They commonly have the associated constipation because the mechanism they use to hold urine, they use same mechanism to hold feces also. Therefore, these two conditions, constipation and these low voiding frequency, going together, and it is called voiding postponement. And this can be seen in a small children, especially due to the distracted playing. This is an innocent condition. We see a lot of children during this COVID epidemic or pandemic presenting with these symptoms because of they have been mostly at home and they are psychologically also get a little bit of disturbed due to their disturbance in routine life. And extraordinary daytime urine frequency is an innocent condition, is usually present very small. They present with very small void volumes, more than 8 times per day. And there is associated the reduced bladder capacity, and sometimes they even urinate every 5 to 1 hour frequency. Extraordinary daytime frequency invariably occurs in young boys and in self-limited. When they grow, it usually resolves, and it's an innocent condition. Then what it is, another important condition is underactive bladder. This is an infrequent voiding, typically 2 to 4 times. We know usually usual child in pediatric practice, we expect them to pass urine 4 to 6 times or 4 to 7 times per day. And here is less than that, is 2 to 4 times a day. And the important, when you look at the history, you can appreciate there's a straining during micturition. And sometimes they voluntarily bend over to push the abdomen and to increase the intra-abdominal pressure to start or to complete the voiding. And they can present with symptomatic UTI, dribbling, and emesis, and also with or without constipation and encoparesis. This is another important condition. These children classically present an interrupted pattern on uroflow with a large post-void residual. If you look at the ultrasound, you can get the last post-void residual, and the basic next investigation is uroflowmetry, and it also shown the typical interrupted pattern. This is what you call underactive bladder. Now we have gone through very important 5 urological presentation, and we see how we are going to evaluate further. The evaluation of BBD start with the medical history. As I mentioned, all those 5 conditions I have mentioned earlier, if you go through a proper and detailed clinical history, you can easily diagnose clinically even. Therefore, elicit the storage and emptying functions associated with the bladder bowel dysfunction, and look at the history of urinary tract infection. Very important to rule out any neurological condition. Therefore, inquire about neurological symptoms, and associated bowel symptoms has to be highlighted and evaluated properly because it's a part of your management. And also look at whether there are any associated symptoms like behavioral issues, because there are enough evidence to show that the attention deficit hyperactivity disorder and the autism spectrum disorders the children with those disorders are having higher degree or higher chance of getting bladder bowel dysfunction. If we look at those behavioral issues also. Physical examination important. Do genital and perineal examination to see any or rule out any anatomical issues. And digital rectal examination, especially if indicated, especially with the if you suspect any perineal issues or any neurological issues. And neurological examination is a must, where you need to rule out any underlying neurological abnormality causing bladder bowel dysfunction. Therefore, you need to look at perineal and genital examination with the proper neurological examination. Then we will do what you call the basic evaluation of the bladder functions through the bladder diary of our voiding observations. And there are some questionnaires, what you call lower urinary tract dysfunction questionnaires, where you can have a score and decide on whether the child having a significant bladder symptoms. To evaluate the constipation, we can easily use Bristol stool form and Brome-4 criteria. Therefore, these are basic evaluation tools we use in bladder bowel dysfunction. If you look at this very simple chart, we can easily use this in our clinical practice, even in the clinic visits. You can look at the urine volume and whether the child is having straining or interrupted pattern, any wetting or incontinence, and how much of fluid child has taken, and the stool type, and how much incorporates accidents they have, and then any comments and observation. This will give you some idea about how frequently or easily you can evaluate your bladder and the bowel symptoms through these type of a simple charts. After that clinical evaluation and basic tools, we proceed to what you call the basic ultrasonography of the kidney, ureter, and bladder. It will help us to evaluate the bladder or any bladder wall abnormalities or any features of increased bladder pressures, and also post-void rectal volume and the transverse rectal diameter, which also give you idea regarding the constipation, the degree of constipation. And post-void residual volume is very important, and there are some calculation to find out whether it's significant or not. For example, if you take 4 to 6 years, 10% is very important. 10% is taken as a significant. If it's in the bigger children, we take as a 6% of the pre-void volume is important as a significant post-residual volume. Evaluation of bladder bowel dysfunction further can be done through uroflowmetry, MCUG or voiding cystoureterogram, ureteromyogram, or urodynamic studies. From these, we mainly use the uroflowmetry, plus or minus MCUG. The EMG and the urodynamic studies are rarely used in our clinical setting. This is another important slides. These are examples of urofrometry patterns. You can see normal urofrometry is a bell-shaped curve. The overactive bladder, they can have a tower shape. Dysfunctional voiding, they have a staccato pattern. And underactive bladder, what you can see is the interrupted pattern, and the outflow obstruction like PU valve, you can see a plateau. Those are the 5 important urofrometry diagrams that you should know when you are interpreting, and sometimes even this can appear in one of your skis even in MD exams. Now we go back to the clinical history that we discussed earlier. The 6-year-old child with history of UTI, and he's having infrequent voids per day, and he having a straining. He take longer time to empty the bladder with constipation, and he has a post-void residual of 20%. What do you think the child is having? He's having a underactive bladder. And your urofrometry, if you look at this underactive bladder, you have an interrupted pattern in the urofrometry. Therefore, in a nutshell, the diagnosis of BBD or bladder bowel dysfunction start with the clinical history and the examination, and you exclude any neurological condition, and you go with the bladder and bowel diary plus or minus your symptom score, and later you further evaluate with your bladder ultrasonography with post-voidal residual and the urofrometry. Urodynamic testing sometimes you need, but it's rarely used in our clinical settings. Therefore, this is very easy when it comes to the clinical diagnosis of this bladder bowel dysfunction. How is it treated? Another important aspect. I'm not going into details, but I will give you the concepts. Management is basically divided into 3 main concepts: the conservative management, pharmacological or medical management, and the very rare phenomena we use, the surgical management. If you look at the conservative management, urotherapy is the main aspect. Urotherapy includes the education, the proper education, or give some insight about this problem and why this is happening, and also it will give you some behavioral advisors, or behavioral therapy can be educated through proper information, providing of the information. Adequate hydration is important because it will increase the bladder frequency, and the child will feel to pass urine. That's important. And then also it will reduce the risk of constipation. Time voiding is very important. Most of these children, we ask them to void 2 to 3 hours early. And after voiding, we request them to drink a glass of water to make sure these two are going together. One of the advices we usually give them is pass or void every 2 to 3 times after coming, after passing voiding, or after toileting, come and have a glass of water. That's very important. Pelvic floor exercises, awareness and the training can be initiated in a little bit bigger children. And Kegel exercises is another important part, and you can further search on that. You can get some idea, but you need to know the term. Kegel exercises and biofeedback relaxation of the pelvic floor is very important, especially in the dysfunctional voiding. And sometimes we can use electroneuro stimulation to relax or stimulate the pelvic floor. This is not much available in our settings, but your exercises, the physiotherapies know these exercises, and biofeedback relaxation of the pelvic floor. Those are the things that we can initiate through your behavioral therapy and through proper education. Bowel management is very important. Therefore, remember, urotherapy is the key with plus bowel management and the constipation management, starting with the laxatives and toilet training, and then kind of sometimes they may need the enemas also to make sure they get the proper bowel opening regularly. The bowel management is a different topic. Early toilet training is very important because it will help them to understand or learn on how to manage their pelvic floor from very early stages. This is one of the main reasons we can see one of the main association with the bladder bowel dysfunction is the improper toilet training. Therefore, it's very important to start toilet training as early as possible. Therefore, it can even prevent that bladder developing of the bladder bowel dysfunction in some percentage of children. Later, if you are in the diastase or you can't manage with your basic conservative therapies, you can think of the clean intermittent catheterization, especially if the child is having increased bladder pressures with upper tract involvement. The clean intermittent catheterization is important. Pharmacological or medical treatment, especially when they're in reflux or increased residual volume in the bladder, prophylaxis is important to prevent urinary tract infections. When they're having, especially the sphincter construction is leading to the dysfunctional voiding, you can relax the sphincters by using alpha blockers. And anticholinergic sometimes important to reduce the discoordination in diastrophic muscles. Therefore, it can be useful in some cohort of children. And again, botulinum toxin is again to import or relax the bladder spasms in some extreme cases. Therefore, medical management has a place. Conservative management is the most important with the urotherapy and the bowel management. Plus or minus your pharmacological treatment, it will give another step or another support for your management. And surgical management is actually not much in this type of a condition. Therefore, dear ladies and gentlemen, we look into this very important condition, and especially the presentation, the urological presentation. We learn a little bit about the uroflowmetries, how you can use this uroflowmetry, or you can, to put together these steps in diagnosis and basic management plan. In summary, bladder bowel dysfunction is an increasingly common pediatric problem, and especially it is underdiagnosed pediatric problem, and is commonly associated with the respiratory reflux and recurrent UTI. Especially you need to suspect these. They come late in his life. For example, especially the children comes with the recurrent UTI early in their life, first 2 to 3 years, but if they come late in life with the VUR and the UTIs, this is a condition that you need to suspect. When treating a children presenting with the recurrent febrile UTI and lower urinary tract dysfunction or constipation, always think about the bladder bowel dysfunction. And the good thing about most respond to conservative treatment and medical therapies.